So first, for most of you who don't know anything about lymphatic filariasis, I'm going to give you a little bit of an introduction to the infection and how it's transmitted. Then I'm going to skip over a lot of the basic science that I've been doing for at least the first 10 or 15 years at CDC and start talking really about the public health aspects. How do we make a program work? What does it look like? How does it function? Then we'll get into some of the specifics for Haiti, and then hopefully the major portion of the talk is really lessons learned, and then how these can apply to some of the global activities. I'll talk a little bit about the life cycle in a minute, but lymphatic filariasis is a parasitic infection. It's actually a worm, and it's a worm which is transmitted by a mosquito. We call it circumtropical in distribution, and though there's always an argument with WHO about exactly how many countries are endemic, it was somewhere between 70 and 80. One of the things that I try to remember to emphasize is that filariasis was, like a number of our tropical infections, introduced to the New World by the slave trade. So initially, it was distributed essentially in every country where you had a plantation-based economy through active efforts, but mostly through economic development. It's disappeared from all but 4. Haiti, Dominican Republic, Guyana, and one very, very small residual focus in Brazil. So, in many ways, I feel like part of my responsibility in the public health context is sort of to keep in mind that historical context, that we have a responsibility to reverse what I would call the living legacy of slavery in some ways. So I mentioned these are parasitic worms. The female worm is actually about this long, but it's thread-like. It lives in the lymphatic vessels. I got into studying these parasites as an immunologist, and I did it because I thought it was fascinating that you had a parasite that was living, in essence, inside the immune response. And it was figuring out a way to avoid or subvert that immune response in order to survive over an extended period of time. These parasites live for 5 or more years, and that's going to be an important part of the story in terms of our strategy. The female parasite produces a stage that circulates in the blood that we call a microfilaria. This is the stage that's picked up by the mosquito. It takes about 2 weeks for it to develop within the mosquito, and then it's transmitted to the next host. What's interesting about this transmission cycle is that unlike malaria, where we're used to talking about the sporozoites being injected with the salivary fluid directly into the bloodstream, these are macroparasites. The larvae are about 1 millimeter in length. They literally fall out of the mouth parts of the mosquito. They have to find that bite wound. So transmission is a very low probability event. Why does it work? Because in most of the world where this infection is transmitted, people are getting hundreds of mosquito bites a night. So a low probability event per event times 200 per night, over the course of the year, you get a really significant infection burden. Most of you will recognize lymphatic filariasis from the clinical conditions that it promotes. Elephantiasis is what we would usually call this in the common literature. I mean, this is how you would probably do a Google search for it. Hydrocele is less commonly recognized. One of the things that I think has not really been well appreciated is the extent to which these are really gender-specific diseases. Elephantiasis, lymphedema and elephantiasis are diseases of women. In Haiti, the ratio of affected women to men is about 10 to 1. Hydrocele, which is the expansion of the scrotal sac, is by definition a disease of men. Many, many more men have hydrocele than women have lymphedema and elephantiasis. It is, for obvious reasons, a hidden disease. From the public health perspective, we can use the prevalence of hydrocele in adult men as a rough measure of the prevalence of infection in the community. in the areas of Haiti where Kathy and I work, 1 in 4 adult men has hydrocele. So one of the things that I'll return to is that the strategies that we use to attack the transmission cycle of the parasite have no impact on existing disease. We hypothesize that they will prevent future disease. But at this point, I think it's important to bear in mind that that's a hypothesis. This is kind of weird, Kathy, that it's switched on here, but not on here. Let us see. No, it's not. Any ideas here? It seems like it's frozen. No? Well, I think there we go. Actually, let's see if we'll go now. While we're doing that, one of the things that the next slide was going to focus on, we just only stick with this, and we just X this and we won't worry about it.
I think I got you.
From current slide, one more. Nope, it didn't do it.
Oh, there you are.
Thank you. From the epidemiologic perspective then, our focus is understanding who's infected and where are they distributed. So what we're looking for is the microfilarial stage in the blood. A further wrinkle or complication here is that in most of the world, the microfilariae are only found in the blood at night, which conveniently coincides with the biting behavior of the mosquito. But from the perspective of a laboratory person that has to go out into the communities, what it means is night bleeds. So you have to go out, you have to sample blood at night, and most importantly, you have to convince people that there's a reason why you're sampling that blood at night. So for many years, my nickname in Haiti was the Lugaroo. You know, the werewolf that comes in the night to take your blood. So a badge of honor, I guess, at a certain level. But it has been, historically, this was one of the major obstacles to really understanding where this infection was distributed. And we really didn't take a leap ahead in the public health realm until, one, we had a diagnostic test that detected antigen, which we could use during the daytime, and two, we had a treatment strategy that allowed us to treat with a single dose. And that was sort of the research side of my CDC career. So in terms of that strategy that we use to really attack the parasite, there are drugs that we can use alone or in combination that will kill the circulating stage of the parasite. That's the microfilaria. These drugs have little or no effect on the adult worm. But if we're looking at individuals that have infection in the blood, we provide a treatment with either ivermectin or dichlorcarbamazine or the combination of either of those two drugs with albendazole. We see a rapid clearance of microfilaria, which is sustained for a period of about a year. So conceptually then, this led to the idea that if we came in with annual treatment, we could remove the reservoir of microfilaria from the blood and we would prevent the mosquito transmission cycle. So what was uncertain, and to a degree is still uncertain, is how long does that have to go on? Our starting assumption was that the parasite, the adult worm, lived for 5 years. So our starting point for the program was then to keep the transmission, to keep the drug distribution going on annually for 5 cycles, and then the thinking was that we would prevent transmission from that point forward. The second thing, which I think I already emphasized to a certain extent, is that we do not expect these treatments to benefit the patients that already have elephantiasis or the men that already have hydrocele. And that's going to lead to another series of issues. In any kind of a public health context, in any kind of a discussion context, often the issue comes up, why mass drug administration? Why don't you just identify the treated people? The antigen test that we use for our epidemiologic studies costs on the order of $3 to $4 US per patient. The drug costs 1 to 2 pennies. The albendazole that we use is donated. So I'm looking at almost 100-fold difference between the cost of diagnosing an infection and then treating it appropriately versus a mass treatment strategy. So what WHO has done is establish sort of a global threshold, which gives us that green light for mass drug administration. It's based on a prevalence of infection in the community of 1%. So that's where we move forward with this. Again, with a limited amount of empirical evidence at this point, our working hypothesis is that we will be able to prevent future disease by using this kind of a strategy. So, in thinking through this, I mean, most of our studies in Haiti with the drug regimens were done in the mid to late 1990s. In the late 1990s, some of the expert groups meeting in WHO began to understand that it was realistic to go after this disease as a global health program. So what made that possible was really some limited number of events. One was the International Task Force for Disease Eradication identified lymphatic filariasis as potentially eradicable. The second thing was the albendazole donation from GlaxoSmithKline for the life of the program. So we had a donation of albendazole for as long as we need it and as much as we need it, which is a great thing. And the third thing was really a catalytic grant from the Bill and Melinda Gates Foundation to get the global program started. It was only $20 million. It sounds like a lot of money, but our at-risk population was 1.3 billion. So in the early, the Gates money came in 2000, and if you look at the bars, the histogram gives you the number of countries that have a functional or operational program. The line gives you the idea of the numbers of treated. We're now hovering around an annual treatment target of around 500 million people a year. So I usually tell people in this kind of a venue, it's the largest public health program you never heard of. And I would challenge most of you to identify another program that has that number of treatments delivered on an annual basis. What's more encouraging is that we're now beginning to see, after a decade here, that there are some evidence of success. So at least 13 countries are at the point where they have reached a point that we operationally believe is consistent with interruption of transmission. We've withdrawn drug treatment in those 13 countries, and now we're entering a surveillance phase, which if you ask me point blank, do we have any clue what we're actually doing here? The honest answer is no. We're learning as we go. But we have some hint then that there's reason to be successful. So over this initial decade of the program, we're looking at, we're not treating exactly the same people every year. Our estimate is that about 800 million people have been treated, or at least once. About 10% of those people, as a global average, are infected, so that gives you about 80 million infected people. And then our best guess is that we've prevented about 8 million cases of hydrocele and about 5 million cases of lymphedema and elephantiasis. So we're beginning to feel like we're getting at the global level to a point where we're actually accomplishing something. Our distribution strategy was always been based on multiple drugs. One of the reasons is if you use two drugs with different mechanisms of action, you minimize the possibility that you'll drive drug resistance. That's one important issue. The second one is that it gives us an opportunity to have a broader spectrum of therapeutic benefit. One of the drugs that we use is albendazole, broad-spectrum deworming drug. What I'm showing you here is hookworm levels in just 3 representative countries. The bottom line, hookworm is a major cause of anemia in children and adults. We can run it out of the community in 2 to 3 years. So there's a lot of additional public health value that comes from the addition of the deworming drug. It was this thinking about the opportunity to deliver integrated treatments that really led to this whole focus on integrated neglected tropical disease programs. And now is the largest of these, the LF program, or lymphatic filariasis, LF for short, is really the platform for service delivery in a lot of these countries where the program is operational. So that's the background. Now for Haiti, one of the first challenges that we were dealing with is characterizing the extent of the problem. As long as we were doing night bleeds, let me assure you, we were never going to have a clue. The game changer for us was in the late 1990s when there was basically a rapid diagnostic test that was developed that allowed us to go into populations during the daytime. So, easiest population to access, maybe most representative, not necessarily in Haiti, is school kids. So, across the districts of Haiti, more than 120, the number seems to change annually. We call them communes. We picked 2 schools at random. We tested at least 100 kids, and this gave us our snapshot of the distribution of infection across the country. Here, red is bad. Red means the prevalence of infection is high. Green or white means it's relatively low. From the CDC side, we did additional surveys to document that even in the low transmission areas, or the low prevalence areas, there was evidence of transmission. We gave that information to the Ministry of Health, and they opted to go for a national program. One of the things I should say, sort of picking up on my historical notes, all of the red zones are the areas where you see sugar cane and or rice being cultivated. And these would be the areas where you would have had, 250 years ago, the greatest concentration of slaves. And so these were the areas where it would have been possible for the parasite to establish. I already talked a little bit about the intervention strategy. In Haiti, we used diethylcarbamazine and albendazole. I have the conversation with Kathy and David every year that the preferred drug is actually ivermectin, which gives me a targeting of scabies and strongyloides and head lice and a better additive effect with albendazole as a deworming drug. Ivermectin donation is restricted to sub-Saharan Africa, and despite 10 years of effort, we have never been able to convince Merck to make it available for Haiti. I'm not really going to talk a lot about the efforts that are focused on morbidity control or vector control because they are lagging way behind. They're much more resource intensive, and in many ways they require an existing structure that we can capitalize on. The FDA program that I'm going to describe does not require any structure at all. You can build it de novo in these communities. So, how does MDA work? Mass Drug Administration, MDA for short. Basically, the starting point for us in Haiti was the recognition that the traditional health structure simply was non-existent in most of the rural areas. Port-au-Prince has some good hospitals. There are a few regional centers in Haiti that were good, but most of the rural population does not have adequate access to care. So if you want to have a distribution strategy that reaches all communities, you got to develop it. So we built on models that had been explored in other countries to look at networks of community distributors that would be responsible for getting the drug out. And basically what you set up is a cascade. We identify community leaders. We expect the community leaders to identify people in the communities that have educational attainment or, let's say, political capital in the community that will allow them to be trusted as the distributors of these drugs. We set up the training cascade, and then we provide the logistic support to make sure that the drug gets to where it needs to go. We had tried house-to-house distribution in Haiti. It was a miserable failure, and so we switched to a second model, which was based on the idea that you have a distribution point, and then our goal is to motivate people to go to those distribution points. Our target is 1 per 1,000 population, so that gives you an idea in a country of 10 million, how many volunteers we have to mobilize in order to get things going. We had tried shorter distribution periods. Very hard to get everybody to do one thing on one day. So the usual strategy now is it's over a 4-day period, 2 school days, Thursday, Friday, Saturday to catch market day, Sunday to catch church. And so across that kind of a spectrum, you can capture a large proportion of the population. Now what I'm going to do is give you a really quick view of sort of the growth of the program with all of the warts and bumps and challenges along the way. CDC actually provided the initial seed funding in the commune of Legon for our MDA. And what I'm going to do is walk you through sort of the rate at which the program scaled up. The key to our ability to scale up, CDC never got beyond that initial commune of Legon until very recently, was, again, the Bill and Melinda Gates Foundation provided funding support to our colleagues at the University of Notre Dame. It wasn't very much money, but it allowed us to make the tactical decision that we were going to go after the red zones. We're going to attack the problem where it's greatest, and we're going to hope that we can bring down the overall infection level. So what I'm going to ask you to follow in the pie charts then, the top one is the percent of the total population. The bottom one is, if we estimate what proportion of infected people in Haiti are in the zone rouge, what proportion of the infected people are we capturing? 2002 was a training year. Basically didn't scale up at all. 2003, we worked with IMA World Health in the north, and then the ministry and some of the other areas to start scaling up the MDA. You can see only 10% of the population, but we didn't do so badly if you look at the proportion of infected people, almost a quarter. 2004, looking a little bit better. 2005, a little better yet. And now what you're beginning to see is what we're not covering. This is Gonaive. This is Port-au-Prince. Two urban centers, two centers that are historically the center of political strife in Haiti. And that's telling because 2004 and 2005 was almost a civil war in Haiti. It was, we don't call it a civil war, but in terms of having, groups of militia representing competing groups marching on Port-au-Prince, it met many definitions. Insecurity became a huge issue for all of our Haitian staff in the program. We had one person killed at a roadblock in Port-au-Prince and came under tremendous pressures from the donors, the Gates Foundation in particular, that we were operating in an insecure environment and putting lives at risk. Balanced against that was the desire of the communities to see the program continue. So we're doing one of these, and the donor backed off. So in 2006, we had no support from any source, and the program basically went on hiatus, which is a point that I'll come back to. So we spent the year looking for donors, trying to convince the Gates Foundation to come back in, and we were fortunate that they did. So in 2007, that funding was restored, and then we were successful at competing for new USAID funding in the same year, and that created the opportunity for us to start thinking about expansion. So we had two sources of money through the University of Notre Dame, the Gates money, and that's really the areas that I'm focusing on in the light green, and in the light blue is the money that is coming from USAID and RTI International. I think they're a research triangle group based on the name, through our partners at IMA World Health. And what we decided to do was to begin to think geographically. So Haiti has 10 departments. We're going to start looking at department by department. But for historical reasons, each partner sort of held on to their traditional turf. So 2008 and 2009, we expanded on that model. But we eventually got to the point, where we're realizing it doesn't make sense to have Notre Dame going here and IMA going there. It's time to rethink the strategy and realign the geography to match with the funding availability. And again, I'm emphasizing once again that we just didn't have the resources to attack the urban transmission zones in Port-au-Prince. Super expensive, super challenging. So this is where we got by the end of 2009. Where there was a realignment of the strategies. If it's green, it's basically an IMA responsibility with USAID money. If it's yellow, it's Notre Dame. This was a ministry responsibility. This was Partners in Health. Notice red, still Port-au-Prince, no activities planned. And that is the map that was created on January 12, 2010 by the partners. They finished their work at 4:30. The earthquake hit at 4:53, I guess is the time there. So at the Montana Hotel, so literally a period of 25 minutes made the difference between everybody being killed in the earthquake versus effectively everybody surviving in the earthquake. Not that there were not traumas associated with the IMA team who were trapped in rubble for 60 hours before they were dug out. So this was obviously another one of those moments where, a crisis of confidence in terms of whether or not the filariasis program is actually the priority for Haiti. So we declared a timeout during the rebuilding period while there were resources brought in to provide immediate relief. And then about a couple months later, the Pan American Health Organization sponsored a donors meeting to allow us to start putting some of the pieces back together again and to look at the opportunities. And the good news for us is that it brought new donors to the table, including my own institution, CDC, which made a commitment for the first time to begin to put money into the treatment activities in Port-au-Prince. So Inter-American Development Bank came in, there were other groups like Abbott and Pepsi, and then what I was particularly pleased by was CBM. Christophe and Blended Mission was the original name. They had the responsibility for developing programs to support the patients with elephantiasis. So that set us up from that point on, where we began to be able to think about closing the gap, which was Port-au-Prince. So for those of you who haven't been there, this is actually one of the nicer areas. Very, very densely populated, absolutely crushing poverty, some of the worst slums anywhere in the world, huge problems in terms of the security. So we knew that at about the time of the earthquake, the estimated population was about 3 million. The earthquake killed upwards of 300,000 in Layegon and Port-au-Prince and Gressier. There was a huge out-migration. When the donor community came in with money, there was a huge inward migration. No one knew what the money, what the exact population was. The only areas of the city for which we had accurate population data were the camps for displaced persons. And as of today, there are still almost 500,000 people in those camps. So we estimated, based on a 3 million population, that we had to organize about 3,000 distribution posts with all that that entails in terms of the leaders, the distributors, the whole logistic network. The biggest issue for us from the logistics standpoint is that in the old days, if I wanted to set up a distribution post, I would get a 5-gallon bucket. I would have the people in the community dump water in that bucket, and that was the water source for the MDA. The end of 2010 saw a huge cholera outbreak in Haiti. That kind of haphazard approach to water was unacceptable, both from the public health perspective as well as from the community perspective. So what we were forced to do, as I'll show you in a minute, is to supply drinking water for each one of the 3 million people that we were going to treat. Huge logistic challenge. Tablets weigh nothing. I can load a city's worth of tablets basically in 2 pickup trucks. So imagine doing that for 3 million little baggies of water. There were funding issues that I'm not really going to go into, just in terms of coordinating the flow of donor money through different venues. That's actually a big challenge. I will give the ministry full credit because they had the primary responsibility for selecting distribution points. They did a good job, I think. They used the sweatshops that you can see. You can't really tell because it was a surreptitiously taken photograph. They used schools. They used the markets. They used all the public gathering places that you can imagine. They were very creative, and what I was especially pleased with is that they moved according to the day of the week. So schools, they did Thursday, Friday. They moved to the markets and central places in the community on Saturday, and then moved en masse to the churches on Sundays. That pile of bags of water is probably on the order of, I don't know, maybe 25,000 bags of water. So now you're going to multiply that by upwards of, what is that, 25,000 times 50 makes a million, is that right? It's a little less than that, times 40. But the point is that it was a huge problem in terms of getting water to the distribution points. That was our biggest challenge. So Some of the sites actually ran out of water. It was hard to keep them restocked because the flow of information is not as it should be. That's something that we think that we can potentially correct. The other thing that was really, I think, a novelty for me to see, in the, again, historic times, if I took the tablets out of the container, I could just spoon those into your hand. People will not take pills out of a hand that's unclean. So there's at least one message that the cholera program got across very well, and that is you have to wash your hands. So that's going to be next year's issue for us in terms of having hand washing and or hand sanitizers available at all of these posts. So what do the numbers look like? The metropolitan area is divided up into 6 communes. This was our best guess at the population. That's how we came up with our 3 million number. We treat by mass drug administration above age 2. We do not treat pregnant women. So we had sort of a fudge factor that we used to come up with our target population. What you can see in terms of numbers treated, it's not so bad. I was shooting for 1.5 million. They hit 2.3. The truth is that I don't know which 2.3 million people were treated. And so the next issue for us is to go in and to do a well-designed coverage survey in each one of those 6 communes, plus the camps, representing a 7th stratum, and to begin to look at whether or not these 2.3 million are residents, or whether they were just people that happened to be in Port-au-Prince on the day of the distribution. So that starts, I guess, the last week of April, and I think that's going to be useful for us both to validate the coverage that we actually achieved, but secondly, to try to identify those health communication messages that got through. You know, we did use radio, we did use TV, we used SMS, we used all communication channels that were available to us. Some of that's noise that no one pays any attention to. So understanding what actually worked in that setting is going to be useful information for us. So this is where we are now, where we have different partners that have responsibilities for different areas of the country. You have to manage multiple flows of money. You all have to more or less agree on the strategy. You have to coordinate around drug requests for the donated drug and around purchases for the purchased drug. But I think the takeaway here is, despite the fact that we talk about Haiti, and this is the first time I've said it in this presentation, the poorest country in the Western Hemisphere, it is still the first country that can claim to be treating 100% of their at-risk population for these neglected tropical diseases. U.S., we don't even come close. We're an embarrassment in the region. Brazil, equally embarrassing. So I think that for Haiti, it's nice to have at least one success. So I say, you know, with this step, basically, you know, we've gotten pushed the rock up to the top of the mountain, but actually, it's still got a slope to it. And so, you know, if we don't keep pushing, we're not going to be able to maintain the treatment coverage for the number of years that we think are likely to be required. And that's really where I'm going to switch gears and ask the question, do we really think that we can eliminate transmission? And this is where I take off at a certain level the public health hat and put the lab long hat back on and say, you know, CDC provided that money at the front end for us to explore the science of LF elimination, and then to see whether or not we could share those lessons with the rest of the world. When CDC put the money into the program initially, my bosses actually said, and this is a direct quote, "You are stupid. You're working in one of the toughest countries in the world in which to work." No argument. I am stupid on many, many levels. But the point was that if in a challenging environment like Haiti, you can make this program work, I would say that you can make it work anywhere. So that's really the issue. So the CDC effort, how much coverage do we need, over what period of time, how do you sustain it? Can you develop a model that you can sustain over a long period of time? So I'm not going to go through the CDC data in great lengths. The red bars show the number of people that were treated each year. CDC provide on-site support for the first 2 years and then backed off, and then it was a Haitian-run program. The one thing I will emphasize is the blue line here is something that I haven't really emphasized at all. When we treat people who have the parasite in the blood with the drugs that kill the parasite in the blood, they will get sick. So within the first 24 hours after treatment, headache, fever, nausea, it's transient, it's gone within 24 hours. But nonetheless, I was healthy, you gave me these pills, and now I feel sick. That is an issue that is a challenge. 25% of the people experience side effects the first year. It went down with each succeeding year. That tells us that we're bringing the infection level down, and when you actually look at the level of infection in the community, that's in fact what we saw. The global target was less than 1% infection. We thought we had achieved it in 2005. You'll recall that 2005 is when our country was interrupted. So it created a situation. I'll skip over the mosquito data, which is a lot noisier, but it still shows a general declining trend. In 2007, I went back, and if I want to know whether or not I've interrupted transmission, my sentinel population is kids. If I've succeeded in interrupting the transmission cycle, I should see no infections in kids. So we use two sensitive tools to look at infection in kids. The antigen, using the rapid antigen test, and an antibody test that we've been working on. Children of 2, 3, 4 years were selected in the cluster survey, and I don't even need to tell you the story here. There was a lot of infection. I think that when we saw these results, I initially thought that the students who were doing the work were doing it wrong, and that was sort of that was very, very disappointing to see. But we had to concede then. All of this work, we did not break the transmission cycle. So we went back and we did our post-mortem. What's the reason? The simple answer is we'll never know with any great precision. We know that by not treating in 2006, we lost our momentum. Infection levels came back up. We estimate that we lost 2 years by missing a single year. So this was a graph that I sent with a great deal of delight to my colleagues at the Gates Foundation. It said, this is what happens when you don't follow through on commitments. So probably was not the best thing to do, but anyway. The other issue, which I think is really important to emphasize here, is that all of our models for understanding the interruption of the transmission signal are really based on this idea that compliance is a random event, and that over the course of 5 years, if I'm maintaining an 80% coverage, on average, everybody's being treated at least 2 or 3 times. When we started going back and looking at this in detail, what we finally began to realize is, to our horror, it's the same 20% each year that are not being treated. So systematic non-compliance was really an issue that was influencing how the infection levels are distributed. The infection level in the non-compliant group remains at its historic level. It's only coming down in the treatment group. The implication here is non-compliant individuals are the reservoir. And if I don't do something to engage them, I'm not going to succeed. So we've put a little bit of effort into trying to understand. There are trivial reasons like the inability to swallow pills. There's reasons that we can address in terms of the lack of education or the inability to get them educational messages across. The one that's a challenge for us in this kind of a setting is the lack of trust. And that's going to, I think, be our biggest obstacle in terms of moving this whole activity forward. The final thing, the piece of the puzzle, is that, remember, our initial strategy was based on the idea that we were targeting the high prevalence areas, and we were assuming that there would be very little migration from low-level infection communities into treated communities. But this was the sticking point. For Gonaive and Port-au-Prince in 2004 and 2005, there was a huge out-migration of those populations because of the civil strife They ended up all over the country, and basically you're exporting from high prevalence areas to low prevalence areas. So whether it's 1, 2, 3, or all of the above, the bottom line is that we don't have a perfect answer. We know that we've addressed one of those problems by attaining full national scale in our treatment. We know that we have a major issue yet to address in terms of our the non-compliance issue. And we also know the historical lesson that if we let up the gas, then we're going to lose the gains that we've already made. So I think I've probably just emphasized a lot of these issues. The takeaway message for the global program is that the simple MDA strategy, which works very, very well in low prevalence settings, has to be adapted in the high prevalence settings. We have to do a better job of community engagement. We have to do a better job of convincing people to comply, to take these medications. And at a certain level, we need to look at ways to improve the therapeutic effect, either through use of bed nets or other sorts of strategies. So it's with that, which I would call sort of a pessimistic note. I don't want to lose on a pessimistic note. I'm going to switch gears a little bit and say, okay, now you know what the issue is. How are you going to figure out how to seal the deal? How are you going to close the gap here in Haiti? The ministry actually did us a great favor, not entirely with intent. In 2003 and 2004, for reasons that are still a mystery to me, they did an MDA in the Isle of La Tortue off the north coast of Haiti. It was horrendously expensive because they had to get all the people across by boat. The people were getting seasick and all those sorts of things. There was no interest in continuing that. So we basically made a deal with them. You discontinue the treatment. We'll come back. We'll do a baseline assessment of where we stand after 2 years. We'll come back after 5 and ask whether or not the transmission cycle has picked up again. So that's essentially what we did. We went in 2005, did a survey across, I guess it was about a 5% sample, and we found that the infection level at that point was less than 1%. So just a few weeks ago, we sent back a Notre Dame postdoc and one of my CDC EIS officers to go back and do another survey. It's actually more than 5 years. It's closer to 7 years. And what we're seeing is there's no recrudescence. So the message, I think, is that for most of this area of Haiti, which is green or white, we probably don't need a full 5 years in order to achieve success. The flip side of that is in the areas that are red on the map, we know it's going to take a lot more. So what's the goal then? Well, the goal is to seal the deal by finishing off the program quickly, within the next 2 years in all of the low prevalence areas, taking the resources that we spare, and then what we're going to do is to focus down, instead of treating a 10 million population, we want to double down and increase the number of treatment cycles and increase the community and social mobilization strategies in those red zones to see if we can get ahead of this. At the same time, Haiti has received global fund money to look at bed net distribution. Whether or not we're actually going to see bed net distribution on the scale that will actually benefit us is an open question. I think because the mosquito that we are using, that's transmitting the infection, we aren't using it, it's using us, is Culex. Most of the traditional vector control measures are not likely to be very effective. The bed nets may be, but any kind of spraying is not likely to be successful. There are other kinds of strategies that I think could be looked at around DEC fortified salt. Now, whether or not any or combination of these will be able to be harnessed sort of in parallel, I think is an open question. For the moment, I'm going to be happy if we can get to twice a year and to see some widespread distribution of bed nets. And I'll accept that as sort of a given. So I think that we're not there. I think we have a game plan to get us to the finish line. Whether it's realistic to think that it can be done by 2015, which is the ministry strategy, I don't think that that's very likely. But the global target for elimination of LF is 2020. I think that's realistic. I think we're going to be able to see that it's going to be possible, even in a challenging setting like Haiti, to stick to that kind of a deadline. I think some of the other take-home messages that I think go without saying in this environment, you don't succeed in global health with one-off efforts. You know, it's go big or stay home. If you're going to go into some of these kinds of efforts, you have to plan on it being at least a decade and maybe a multi-decade effort. So I'm very fortunate to be in an institution that has supported me through that effort. The second thing, which I think, again, I'm preaching to the choir here, is you can't tell where you need to go if you don't know where you are. You have to have some kind of effective monitoring that allows you to really target your resources effectively. And the third thing I think is really a given. No single institution can ever succeed on a national scale with this kind of program. And one of the challenges that we all have in global health is partnering is impossible, but you also can't achieve without it. So, you know, it's the old you can't live with it and you can't live without it scenario. You've got to make sure that it happens. So I'm focusing only on the LF side of things, which is a portion of my portfolio. I'm doing a lot more stuff now in water and sanitation. I think that there are lots of opportunities here for us to begin to use the infrastructure which we've developed and look to see whether or not it can be exploited for other types of programs. Elimination of malaria from Hispaniola is a possibility. It's the only island in the Caribbean where there's still transmission. It's not a very efficient vector. We've got a huge boost from Jimmy Carter, who has made it one of the, let's say, advocacy priorities of the Carter Center. We're also looking in the cholera era at ways that we can begin to use the platform that we've developed for health messaging. I think that, you know, there are no other programs in Haiti that are reaching 8 million patients a year. So that gives us, I think, a very good distribution network. How to use that network is one of the things that I think needs to be decided. In any case, I think that, you know, I would say from the very beginning, where it was the first drug study that we ever did was only 20 people. And it took us weeks and weeks to get to a point where we could get those 20 people through the treatment cycle. It's been really dramatic to be given this sort of professional opportunity to participate through the development of the program and the ramping up, and to see that it actually fits into a global health context. So I feel very fortunate on that side. Echoing that partnership issue once again, it doesn't happen by only CDC. It's not only Notre Dame. It's not only the Ministry of Health. It takes a lot of people working together. Our original partners meeting, which were 4 people sitting basically in a closet, you know, we're now looking at 30 and 40 people. It's much more challenging to coordinate. But ultimately, the sustainability of the program and the success of the program is really going to be a function of our ability to keep everybody around that table. So with that, I'll give you a few moments for questions, and I appreciate your attention.
I think your program of, obviously, the volunteers and the networks, once that's set up, even if this is a limit, you need to go after something else.
Right. No, I agree with you.
Kim in South America, you know, treated multi-resistant TB the same way we treated by doing a very similar thing.
Now, I like the way that you describe that, and I think that as I talk about these programs, you know, CDC has this focus on disease eradication that goes back to smallpox, and it's sort of, you know, when you join up, they kind of tattoo it on you. So you wear that badge. But I think of it as sort of the planes stacked up to come into Hartsfield Airport. They, it goes back 100 miles. You can see them. I can see that the plane for LF is approaching the landing zone. Now the challenge for us is identifying what is the next plane in the queue so that we can take the energy that we put into developing this platform and making sure that we translate it into another health activity so that we sustain the effort. To develop this kind of an effort de novo is expensive. Our costs in the first year within any zone are high. Let's say on the average of 60 to 70 cents per person treated. By the second year, it goes down to 30 cents. So you get a huge economy of scale as you move forward. We've paid that in. Somebody else needs to be able to pick up the pieces and make sure that we sustain it.
So I came in late, sorry. I don't know if you mentioned anything about this, but is there any work on trying to see whether or not genetically modified mosquitoes or some kind of biologically modified mosquito could help?
It's a great question. I think that the answer is yes, but the priorities around anopheles for malaria and Aedes for dengue, this is QLEX. So we are third in line. And the reality, I think, for us is that I'll be done in Haiti before anybody gets around to working on genetic modification of QLEX. It's a horrible thing to say, but I think that I can't count on that sort of backing me up. Sort of the question that fits there is that in sub-Saharan Africa, where Anopheles transmits both LF and malaria, I think there's real hope that the malaria control efforts will do more to eliminate LF than I will. I can live with that. In the areas of the South Pacific where Aedes is the vector, again, there's such a focus on preventing the devastating periodic dengue outbreaks that I think we're going to see, it's probably going to be Wallachia as the driver for that. But I think it's likely to happen. But, LF has been something that has not really been a research priority for any institution other than the Gates Foundation for the last, let's say, 15 years. So if we took the foundation out of the equation at this point, I think it's fair to say that we would be dead in the water. What we're hoping is that as we move into the surveillance mode, where the reality is we don't have very good surveillance tools or strategies, the pitch that we're making to the foundation now is around development of a surveillance strategy that's consistent with the health status and the capacities in countries like Haiti. So we're not there yet in terms of having something that looks reasonable.
Haiti and the DR share a border. I guess it's kind of the borders in the mountainous region, so there's less of an issue. Is there any cross-border? What's the DR doing?
Yeah, it's a great question. I'm glad you asked it. The DR has had a program that moved in parallel with the program in Haiti. The focus for them, or the distribution, has always been very spotty. And there was one major focus in the southeastern part of the country in an area they call Bararona. And I'm not sure I could put it out on a map, but I couldn't spell it. But it's Creole speakers. So basically, the persistence of LF in Haiti and the DR is related, at least in part, to the influx of Creole speakers over the border. There are historical foci in the slum areas in Santo Domingo and an area called La Cienega that treated those. The Dominicans have been very slow to recognize some of the other historic foci. For those of you who are baseball fans, all the shortstops and pitchers come from San Pedro de Macorís, and that is also a transmission zone. The biggest challenge, though, and this is true for LF, malaria, and dengue in the DR, is that the Dominicans will not ever address these programs completely until they extend health care to the Haitians that are working in their country. And so there's a little bit of a historical animosity between the Spanish speakers and the French speakers on the island. And the Dominicans, I think, have been relatively slow to shift from sort of demonizing the Haitians that are in the countries to sort of engaging and working with them. So it is an issue. The DR, in principle, will finish before Haiti. There will still continue to be problems, especially around malaria.
Anybody doing any research to help those people who are already infected?
Yeah, I think, in fact, there's a lot going on, and that's almost a separate talk in some ways. We used to think that, again, I was one of those people that in the early years was providing the elephantiasis patients every time I saw them with megadoses of DEC, and then realizing it wasn't doing anything for them. When we finally got the antigen test, we realized that patients with lymphedema and elephantiasis have lost the infection. It's gone. The damage from that infection persists. And the progression of the disease is not related to the parasite, it's related to secondary bacterial infections. So the focus for the lymphedema patients is really around skin hygiene. You know, it's the same kinds of strategies that we use in the U.S. after women have had a radical mastectomy, which removes their lymph nodes. You might use compression garments, you might focus on hygiene, you might have exercise, you might have elevation. Same principles apply for the lymphedema patients. If you can prevent the acute attacks, you can keep those patients from getting any worse. And if you can prevent them for a long enough period of time, you get some clinical regression, not necessarily in the volume, but maybe in the quality of the skin. And so you get skin softening and maybe less fibrosis. So that's the CBM job, is to begin to try to implement programs in Haiti around those kinds of models. For the hydrocele patients, it's surgery. And the major driver there is the surgical costs. And you know, you're in a health system where physicians have to make money. So there has to be a profit associated with hydrocele surgery, which means that the cost of that surgery ends up being a major barrier, both for the patient and equally from the public health perspective. We can't afford with the budgets that we have to address the need. So it has to be through partnerships with groups that have the ability to bring surgeons in or contract with patient surgeons to provide the services.
How do you address the non-compliant population that you've never eliminated?
Yeah, I think that for me is the $64,000 question. I think usually I have to be honest and say that, you know, as a lab scientist, you know, you always figured the social scientists were just about the lowest things on the evolutionary scale. And so there's been a great deal of humble pie as I've had to come back and realize that we need to engage with these groups. So most of the things that have been recommended thus far are unattainable in the public health context. We simply cannot engage every non-compliant person one-on-one. So the strategy that we're trying to use is to reduce as many of the barriers as we can, to build the trust, which is, I think, the most important issue here, and to look at the health communication messages that at least can be motivational. We are not there. I think that that's where the work, not just in Haiti, but globally, there needs to be that active engagement with the sociology and the anthropology communities to help with that. So I've gone from being somewhat dismissive of those specialties to being their biggest boosters. So, yeah.
So is there any kind of program to educate those people about the disease in Haiti?
Yeah.
So in order to establish trust between the local leaders and the rest of the population?
It's a good question. I think that we had the luxury in Layagon of having health educators that were out embedded in the community. And so they were having community meetings and going after church to talk to people in the church, etc. We've not been able to take that model to scale. And so, in truth, across most of the country, I think the level of health education is below where it needs to be. Now that the program has gone to national scale, we're using the media, mass media, a lot more around, you know, videos and radio. We've even got a soap opera that's been developed to play on the radio. I don't honestly know how effective those messages are. And and my suspicion is that they're only modestly effective. We're looking also at, very, very short messaging that you can get around SMS. And I think that you need to get the computer. I think that those are things that also might affect a segment of the population, but they're not achieving what you need to achieve. The best solution, I think, in terms of health education is to work through the schools to start getting these things into the curriculum. We're not there yet. And I think, again, this is one of those cases where I would probably argue that the most important messages to get across are really around the wash, the hand washing, sanitation, hygiene messages. If they can be the point of the spear, then we will follow in behind them. But we're not there yet. I think that the dirty little secret in the global health community is we don't do a very good job with health education. It's underfunded. There are a few people that are doing a great job with it, but those messages aren't always being translated to other folks.
Soccer player endorsements of treatment messages or something. I mean, we
tried that in Brazil. I'm not sure how effective it was. We've not really gone that way in Haiti. We made a conscious decision years and years ago because of the episodic coups in Haiti to stay out of politics. I think at the time that was a wise decision. Maybe it's something that we need to revisit because the president of Haiti is an entertainer. So maybe this is one of those cases where you use his entertainment skills as a way to get the message across. Have him do one of the promotional messages or something. I think we're at the point where I don't have quite the same fears about the political engagement that I did. So maybe we're a better position at this point in terms of engaging all of the possible help that we can.
All right, thanks very much.
Well, thank you for all the questions.